mean, survival tactic to stay awake during the night, to keep on going so they don't have to lie down. But on any food, I take meth, I'm not hungry anymore. Maybe I'll drink a bunch of Mountain Dew. That's what my diet becomes, Mountain Dew and meth. What does that do to your teeth? Terrible teeth. But if you're a kid at home, you get the same dry mouth. But someone's there brushing your teeth, you got good hygiene, you're never going to have a problem. Keep taking meth, don't sleep, what happens? You get paranoid, get psychotic, start scratching, get all the ulcers, that kind of thing. Doesn't happen for kids. They take a regulated set amount every day. The same drug. Exact same drug. Drug in the same class.
Welcome to another edition of The Crisis Storm, where we're talking about the impacts of homelessness, of substance use disorder, of increases in crime, and the many aspects of things that impact our community that add up to a crisis storm. Here with me today in episode 4, we have Dr. Ian Mitchell, emergency room physician from the Royal Inland Hospital here in Kamloops. Welcome, Eamon.
Thanks so much.
Maybe for the audience, can you give us just a little bit more of your background as it relates to substance use disorder and what you're seeing in community in general?
Sure. Generally I figure if I'm in a room talking to people, it's usually about drugs, because that's something have always been interested in, and I've been studying drugs now for almost 40 years, starting with a bachelor's degree in pharmacology and then medical school and a residency in emergency medicine. And part of that, I did a rotation in toxicology down in New York at the Poison Control Center. So I've always been very interested in poisoning and overdose and drugs and really the effect that has on society. That's kind of come up in a number of ways. I was the physician lead here for the program to provide the first naloxone distribution from the emergency department for people who suffered an overdose. Come to the emergency department. We were the first emergency department in Canada to distribute naloxone kits to those people. I've also been involved with cannabis research and cannabis authorizations as a physician. This is a way to decrease the amount of opiates that many people are taking, often for pain management and sleep management. And then more recently, I've been involved with a medication called Ketamine, which has its small role in the overdose crisis, but is now coming up as far as a new treatment for depression and other kind of psychiatric illnesses.
Wow. So you've seen a fair bit, I would imagine, from an emergency room physician perspective of the crisis in our community surrounding overdose and the reliance on substances. Maybe tell us a little bit about that, what you've seen escalate and if things have changed since the last time we had you in the studio since 2021.
Yeah, I mean, things have certainly gotten worse, and I would say that's kind of a steady thing. And when we talk about overdose crisis, and overdose was kind of a thing that happened before, because it's not really an overdose crisis now. And overdose even is a funny word on its own. Overdose, we say, okay, well, you took too much of something that generally you knew what was in it. So, if I just ended up taking too much of heroin, for example, that's an overdose. Okay, and it's easy to do that if you don't know how much is in it, which is the big problem with the drug supply. But we don't always apply that word to other things. Like if you get really drunk one night, no one says you overdosed on alcohol. You knew that there was Jägermeister in there. You drank too much of it, but no one's ever say, oh, that was an overdose. No, we say alcohol, intoxication, whatever, but nobody ever says you overdosed. So there's kind of specific directions that we put that word, because there's a lot of stigma attached to it. Nobody ever says, I overdosed on booze last night. But now the problem's not with overdose. Now the problem's with poisoning, which is where you don't really know what you're getting. You know, if you go up and ask for Jägermeister and they put something else in your drink, well, you didn't overdose, you were poisoned. And that's really what's happening now in our streets, is that people want heroin. They prefer a measured dose of heroin, but they're getting fentanyl, carfentanil, benzodiazepines. Xylazine now is the latest kind of thing to come up, and we can talk about that. So it's really a poisoning crisis more than an overdose crisis. And that's kind of important because you could say, well, you know, I've got tools like naloxone to reverse opiate overdose. That's no problem. I can reverse that. We've got medications, but people are also being poisoned. So, for example, if I send someone to treatment now for opiate overdose, they've also been taking in lots of benzodiazepines, lots of Valium-like drugs. So when they go to treatment, now they're facing not just opiate withdrawal, but benzodiazepine withdrawal as well, which makes their medical case much more complicated.
Mm-hmm. So you've seen an increase in this dramatically?
Yeah, and that's, you know, we've seen almost no heroin on the streets now. It's all fentanyl or carfentanil or the benzodiazepines. So we've gone from, you know, fentanyl was the big scourge, and then we got into benzodope, which is the Valium, Ativan type medications that are added to the heroin. And that changed everything for the people at Downton Side, people up here, because that's not something they were expecting. You know, again, you're being poisoned. So they're expecting heroin, and they know how to deal with that. You know, there's walks or whatever. But these benzodiazepines added into it, all of a sudden you're not making memories. You're not waking up even with naloxone. You're just down for 12 hours. And while you're down, you're withdrawing from the opiates because you never got those in the first place. All you got was the Ativan, the Valium-type drug. Mm-hmm. So that complicates the picture. Now we're seeing rising really right now, and certainly since the last time we spoke, is a medication called xylazine, which is a veterinary anesthetic that was very commonly used in Puerto Rico. Ended up coming up into the drug market in Philadelphia. A lot of Puerto Ricans live there, and then it's now spread up into Canada, and we're starting to see it, and that's associated with very disfiguring wounds and, you know, big, huge sores, wounds that are very difficult to treat. And again, it's not affected by Narcan, so you get the xylazine and you're just out and you're kind of walking around dazed for a whole day. Not really on opiates, but just kind of out of it. Mm. So there's all these new things that are coming up, and we don't have treatment for that. We don't have any xylazine, you know, treatment either. And the benzodiazepine treatment is pretty minimal. So all these new things are being added in to make it a much more complex soup of what's getting into people's blood supply.
Okay. This leads me back to something we talked about in 2021. You, at the time, were advocating very much around safe drug supply. You know, you made a very compelling case that, you know, in Europe, for example, they haven't had a lot of the same crisis situations within community because they had safe drug supply.
Yeah, that's certainly a part of it. So places like Switzerland, for example, when you provide opiates to opiate users, then first off, they don't have to go out and steal stuff or engage in sex work to fund their own use. They don't have to sell drugs to fund their own use. So they're not opportunistically looking for people to sell to. So that just kind of narrows the whole spectrum of people who use, and then treatment can be offered. And by having a pure drug supply, you avoid the drug war wounds of ulcers, infections, HIV, for example. Europe's in kind of an interesting situation right now, and they may be forced to change because they've still been they've still been supplied with mostly heroin. But the Taliban has just massively cut back heroin production. And so they're starting to see fentanyl in the UK where they never really saw it much before. So they're just on the tipping edge of what we've been experiencing. And we're going to see what's going to happen over there because it's going to be dire.
So with the situation around safe drug supply here, what has happened since 2021? You know, where are we at in the provision of safe drug supply here, and Where do you see it going?
Yeah, so there is some safe drug supply happening in British Columbia to some extent, and that's mostly medications like Dilaudid. But other medications like morphine. So we're getting there. But when you look at the numbers of people who actually can access that in British Columbia, it's still a very small number of people that are able to access that. In addition, we've had decriminalization of drugs in BC. So some of the hard drugs people can have personal amounts without being arrested, and that's certainly a step forward. It doesn't supply people with drugs. It doesn't help them obtain a safe supply. And I'm sure you heard there was a gentleman who started up his own store and was going to sell all these things out of a storefront in Vancouver, and basically got arrested on day one for trying to kind of supply clean cocaine and then that type of thing. Then there's Alberta, which has gone very much in the way of, we are not doing safe supply at all. That is their mandate. That is their ideological concern, that they don't believe in that. And they're kind of were advocating that they're going for this Alberta treatment model and everything was going great. And since then, they've been posting terrible numbers and massive overdose increases. So certainly the Alberta model of treatment, of restricting safe consumption sites, of avoiding safe supply, has not done them any benefit, and seems to be showing terrible numbers.
Now, you started off by saying that things have gotten worse since 2021.
Yes.
But that is kind of in opposition to what you just said around BC doing better than Alberta. Can you provide some
I wouldn't say
clarity?
BC is doing necessarily better than Alberta. BC is because the numbers, I don't think, are that much different between the two. So I don't know that we can show that the safe supply that we do offer at BC is having a big effect, but partially because it's just not distributed that to that many people. So it would need to be blown up in a much bigger proportion to actually have an effect on people.
That safe supply is limited to certain drugs, I would imagine.
Yeah.
And are we reducing, or are we seeing a reduction in the number of people that are leaning towards opioids, where that safe supply kind of fits in?
I think there's people that want to access that and want to not have the mystery drugs that are on the street. Mm-hmm. Part of the problem can be, well, if you're with the supply, is that, well, it may not be potent enough, for example. So, you're trying to replace the fentanyl that people are taking, and you have to give them massive amounts of fentanyl, far more than we are comfortable giving as physicians. So with that, then if you're getting a safe supply, but it's not meeting your needs, then you're going to go back on the street. And so you've got to kind of try to meet people where they're at as far as be that. And then if they've already been using the benzos, for example, in addition, well, how do you put that in your safe supply, or do you want to put it in your safe supply, or how do you deal with that issue? So it's certainly complex to kind of replace everything, but with a safe supply, then you much decrease the danger of overdose and poisoning.
Okay. I know that the public struggles a lot with all of this, and the ramifications or the fallout that happens as a result of it. I think from an overdose standpoint, there's sort of two clear groups, if I'm understanding correctly. One is not the atypical user, the person at home that is doing it recreationally, that you would not associate it as an addict. And the other is obviously a person that is perhaps homeless, street entrenched, dealing with pain or pain management issues, mental illness, things of that nature. Do you see it in that way?
Yeah, I mean, there's always kind of going to be the street entrenched drug user, and but there's still people, and we should look after them to the same extent. And a big part of the issue they have is being homeless, and a big part of the problem the public has is open drug use in public. And for a lot of those people, if they had a home, they wouldn't be doing their drugs in public. Just like you and me. We'd be going and taking our drinks at home. We wouldn't be drinking on a bench. But we have a home to do. But if you don't have a home, well, where are you going to do your drugs? Well, you're going to be on the street. So it wouldn't be better to house them? So that's kind of step one.
Yeah.
is getting more housing available for people who want it. And I recognize it's a challenging thing, and obviously you've spoken to people with regard to that. And that's really the first step. Is like, well, it's it's hard to get people out of drug use if they're homeless. If you can provide them with some home, then you've kind of got to give them a foundation to begin. But I would absolutely agree that this is hard for public to swallow. Is okay, well, why are you giving this guy a home? Why are you giving him drugs? I got to pay for my insulin. Why are you giving him pre-medications? That's a hard pill to swallow. But when you look at the dollar spent versus the dollar saved on healthcare, every time harm reduction wins out. If you house people, it's so much cheaper than having them on the street. Time and again, we see that all these investments in healthcare, in housing, pay off dividends in the long run. Unfortunately, that's not always with the kind of 4-year political cycle that we tend to have, and can't really show results necessary in that time frame.
Right. What about the overdoses in homes? When I read the coroner's reports, it seems that we have a very significant number of people still overdosing in their homes, not necessarily the street entrenched people. Do you concur with that?
Yeah, and I mean that's come out of the unregulated supply. Is that if you don't know what you're getting, then it's very easy to overdose at home. If you know exactly what you're taking, there's not going to be a problem. There are people who order online from the gray market and get pure fentanyl. They take it, they never have overdoses. So it really comes into, well, I bought some cocaine, but it's got fentanyl in it, and I didn't know that. If I didn't test my drugs, then I'm just going to use that, and I'll just die at home. And that's pretty. And there's no recourse to that. Well, how do you fix that? So
how do we fix that? I mean, how do we deal with the situation of this dramatic increase in overdose by people needing to lean towards? There seems to be an increase in disparity even with people in their homes. An increase of people overdosing in their homes. Obviously, the harm reduction approach doesn't apply in their case because they're already housed. Mm-hmm. So how do we deal with that situation? How do we deal with, how do we provide a safe environment to those parents who are concerned about their kids and their kids are feeling trapped, helpless?
Yeah, and I think that's a big consideration as well. What do you do about these kids? There's no harm reduction available for children or for people under 18. You're not allowed to give it out. So they're just on their own. And in ways that makes it a lot worse because they don't have access to clean supplies, whatever, and have to go more underground, face more risk. So that's a lot about accessibility. And I think drugs are more accessible than they have ever been. You can order them online and that type of thing. It's, it's not just that you go downtown and meet somebody, although I think that's, again, more easily done. And there's certainly stories in Vancouver of some of these safe supply medications ending up on the streets being sold. So, for example, if you've got someone who's using heroin, fentanyl, you give them Dilaudid, which is a medical pill, for safe supply, but they're like, it's not strong enough for me, so they sell those and buy fentanyl. Okay? So then those pills are going to end up on the street. And that's been part of a problem with safe supply, is that we're not giving the right medication or not giving it strong enough. So that's what's inevitably going to happen. So in Kamloops, my understanding is a lot of physicians don't do much Dilaudid, for example, because it's just not potent enough.
Right.
But as far as, the home overdose happens partly because of availability. We saw that in the States with the oxycodone kind of thing, that when people had access to massive amounts of opiates whenever they wanted, most of them were fine, but sure, someone would overdose. Absolutely. And I don't know that there's much you can do about that aside from cutting off that kind of crazy supply. I mean, that was a massive marketing thing and involved lots of essentially criminal behavior on part of Purdue Pharma. So kind of need to go after that aspect of things as well. So there's lots of people who would argue, well, that shows that safe supply doesn't work because you had oxycodone as much as you wanted all the time and people were dying. And absolutely true, but it was kind of being pushed on them. It was made far more available than it needed to be. And certainly if you're looking at kind of a regulated safe supply, that's not how you would be doing it. Okay? And I think there is room at some point for a store that would provide regulated amounts of pure drugs, cocaine, methamphetamine, heroin, all those kind of things.
Like a government regulated or a government divisional cannabis store.
Yeah.
Okay. You think that that's the answer?
I think that's one of the answers, and it would be better than the current system. You know, are people going to say, would there be problems with that? Of course there'd be problems with that, but at least you'd have regulation. You know, and that's, you know, we look at smoking, when you look at alcohol, you know, that's why we have fewer deaths than we should, because we have regulation. And, you know, for alcohol, it's not great regulation. We used to have much more stringent regulation. But now you can pretty much get booze anytime, anywhere, so, or, you know, but a lot more openly. But people aren't dying as much. And for smoking, I would say we've had a big success with regulation. And, you know, how many kids, you know, the vaping's a whole other story, but smoking, how many kids are smoking these days? That's just been going way, way down steadily over time. And that hasn't been prisons, that hasn't been cops, that's just been regulation, keeping it out of the hands of kids. So you can say, well, kids could smoke anytime they want now, but they don't. You know, there's no big illegal market for cigarettes for teens right now.
Interesting.
Crisis Storm will be right back after these messages.
We live in a world of conversations about life and survival. On a daily basis, mankind continually seeks a way to make our human experience better on all levels. We seek a way forward. Permit me to invite you to one of such conversations happening right here in Kamloops. AIMCanada Mentorship Society and Mastermind Studios are putting together a special fundraising dinner towards the production of a documentary film series titled Finding a Way Forward. The documentary series will periscope the crisis storm in our community, including homelessness, mental health, drug overdose, crime, and communication breakdown. Guest speaker is the Executive Director of the Canadian Mental Health Association in Kamloops, Mr. Alfred Achoba. Music will be provided by the virtuoso himself, Jeremy Nishaw. You will also witness a thought-provoking art installation titled Not All Dolls Live in Houses from the talented Isa Jessica Jordan. Don't miss out on the mouth-watering dinner, which will be a Greek buffet with vegan options and lots of refreshments to nourish us. Bring your family, neighbors, bring your friends to this fundraising dinner in support of community mentorship and the development of a Kamloops-focused documentary film series to find a way forward.
On the 23rd of February 2024, a prestigious event will be held. AIMCanada Mentorship Society and Mastermind Studios are putting together a special fundraising dinner towards the production of a special documentary film series titled Finding a Way Forward. To get tickets, go to www.findingawayforward.com. Have you ever considered launching a professional video podcast? Or creating a video-based interview, but felt daunted by the task? You may have wondered how to begin, how many cameras you need, who to interview, what to say, what kind of film set do you need, lighting, sound, what editing to use, and how to attract viewers or listeners. Did you know that Mastermind Studios can produce 4 to 8 video podcast shows in a single day, complete with recording, editing, and distribution? Contact us now for your free consultation. Let's explore the possibilities. We can work together to turn your maybe into a resounding yes. Give me a call. mastermindstudios.ca. Give us a call right now. 250-574-6902. I want to sort of shift over to sort of public perspective again for a second, if that's okay. We talked in 2021, and I want to get your perspective again now, still today, 4 or 5 years later from the last time we spoke about this. There has been just a tremendous percentage of the public that are feeling, for lack of a better word, compassion fatigue. They are just tired of it all. It's impacting them. It's impacting their families. They're fearing for their safety. And they just feel quite often like this is just a never-ending crisis. So they have crisis fatigue. They have compassion fatigue. What do you say to those individuals, those families? And, you know, regrettably, it's a very significant number in our population here in Kamloops that are just feeling enough is enough.
It's, you know, if you're living in downtown Vancouver and you're living in a condo in Dublin East Side, I could see that you're going to have issues. I walked to Main Hastings last weekend, just to kind of see what the situation was. It's pretty dire down there. But you talk about people being scared and people getting fed up and the homeless camps and you know, clean the streets. That's what I hear. But part of it is also, I would also ask the question, why are you feeling that way right now? What factors are making you feel, and then it's not, I'm saying it's not a problem, but there are agencies at work that are trying to make you feel that way. And I'm seeing this in San Francisco, and I'm now seeing in Vancouver. So San Francisco, there's all these very well-funded organizations that are kind of trying to elect officials that will clear homeless people, throw them in jail, do all that kind of thing. In Vancouver, we're seeing it with Chip Wilson, the founder of Lululemon, is funding documentaries by a guy called Aaron Gunn. And you know what that is, you know. Yeah. And so Vancouver is dying. You know, and that's been the message down in San Francisco. San Francisco is dying. It's a dying city. There's homeless people everywhere. It's a misery. And the tourism board has asked them to like cut it out because like they're scaring tourists away. And when the tourists come, they're like, you know, what's the deal? Like, this is a lovely city to visit. And sure, there's a couple of pockets. So we're seeing Aaron Gunn, Peter Poliver, Chip Wilson funding all these initiatives, these moves. I mean, you watch that movie to make you think that Vancouver was dying and it's scary. That's exactly what it's about. It's about propaganda.
Yeah, there's a certain bias to it. I mean, most documentary films pick a bias and run with that bias. It makes for good television.
Yeah. But there's a real organization here, right? And they're pushing politically as well. As a BC Proud, I think it is, that Chip's involved with. So there's, you know, and this is all being funded by the people who have the nice places in Vancouver and want to like clear out down the east side, get all the funding, get new buildings built, like, and that's fair enough. But they're not out for the common people; they're out for the rich people, because the rich people don't want the least of this. So they're funding all these efforts to agitate, to kind of cause more issues and to create issues. So I think there's, to some extent, an unrecognized thing by most people that there is kind of these background organizations working to make people feel scared, to make people feel more unhappy about the current situation than they should be. Because realistically, it's not that scary to go to Vancouver. You know, you're not going to get poked by a needle just walking down a regular street. That's just not going to happen to you. But that's the impression people are getting. So I just kind of wanted to throw that out there. But I'm not going to say that compassion fatigue doesn't exist. If you live on North Shore, and there's areas which, you know, have lots of trouble, and, you know, we see that in the emergency department. I know where the trouble spots in town are. And I think it has gotten worse through COVID. Mm-hmm. COVID was hard on everybody. And, you know, that kind of took a lot of compassion out of people at the get-go. We're seeing, you know, as a result of COVID and now kind of economic instability, you know, the grocery prices are rising, housing prices are rising, everything's got out of hand. I see far more people coming in to the emergency department who have depression, anxiety related to their housing. You know, people who never thought they'd end up on the streets, and now that's where they're going to go. And it never occurred to them that they'd be in that position. But that's not, you know, grocery prices. That's not the fault of homeless people. Why are grocery prices so much more expensive now? Who's profiting off that? You know, that's got nothing to do with homeless people, but that's part of our anxiety.
Mm-hmm.
Part of the compassion fatigue. I'm running out of money. I'm running out of food. I can't afford to house myself anymore. My job might be cut. And there's homeless people that are getting all this money. So, you know, there's a kind of famous thing of, Rupert Murdoch sitting with, 99 cookies. And there's a worker with one cookie in front of him, and Murdoch saying, you better watch me, that immigrant's going to have your cookie. So I think there's a deflection here, and that, you know, these rich people who are funding all these campaigns, if they put that money in some housing initiatives, maybe we could make the city better and deal with the problem, rather than saying, well, the answer to this problem is to imprison these homeless people, or these people who, you know, either you get treatment or you go to jail.
Mm-hmm.
Like that's never worked. No sign that's ever worked for people. But that's the model that Alberta's now pushing, is, you know, mandatory treatment.
Okay. So you've done a lot of work over the last decade with treatment, rehabilitation.
Sure.
I
I wouldn't say I've done a lot overall, because mostly my work is in the emergency department.
Right.
We do, though, have an interesting project going on right now at the Maverick. You know the Maverick project up
part of
that's run by Wellness.
Yep.
So we're running a pilot program right now where most recovery houses are abstinent or clean. We have a program where people coming in for recovery are given education on cannabis use and how they can use it to help with their pain, their sleep, and we supply them with cannabis to a certain kind of group of people in there to help them manage their symptoms, become more educated, and ultimately, as I say to them, you can smoke your brains out 24/7 if that's what you want, but here's a way that you could use it better. And we're having great success with this. And so there's innovative things that I think can still be done for recovery. My view of recovery facilities overall is kind of dim. A lot of them are still based on a 12-step program. A lot of them are based on religious kind of foundations, and they really don't fit in for a lot of people's lives. Most of them are abstinence-based. Many don't offer substitution medications like methadone or Suboxone. They just do cold turkey kind of thing, and that's incredibly dangerous for people, because once they get out, they're at a very high risk for using again, and very high risk for dying, because they haven't been using for such a long period of time. So I think there's a long way we can go for recovery. I think there's a long way we can go for providing treatment access, and that's 100% all part of it. And I'm never going to say that's not part of these things. That's all just methadone or whatever. But the current regulations over recovery houses are lax. Recent kind of sexual abuse allegations, all that type of thing. You've had people, recovery places working for political campaigns, that type of stuff. So there's a lot of room for regulations, a lot of room for just more in general. I mean, that's one of the things we have people talk to regularly. They say, I can't get my kid into a rehab center. It's too expensive, or they've got too big waiting lines. We need to work on what is their effect. You put $10,000 for a month of in one of these places. What's your likelihood of succeeding 6 months out? We need to collect that data, because that data doesn't exist. And if it's not anything significant, then why are people paying that much money for it?
Good point. So, but does a recovery house, in your experience, from what you've seen over the last decade, programs like Ask Wellness, programs like CMHA, that have a harm reduction model in place, are they working from your perspective? Is there hope? Are people getting better? Are they recovering and getting back to a productive life?
You know, when you look at the stats, most people will recover with time. You know, and it may be 10 or 15 years. But with alcohol, with most drugs, there's a good chance over time that people will recover. So part of the thing is just keeping them alive until that can happen. And that's what's happened to so many of them is that, you know, every timeline they go on, they just die before they get that chance. And I guess that was the whole thing with Narcan and naloxone was that just, okay, well, I know it's not going to fix the problem, but it's going to keep someone alive today. Then maybe in a year, they'll go to recovery, and that's okay. I would feel bad if I never gave someone the chance.
If you could get a message out to the public, what do you think the misconception is that they have? What do you think is something that they really need to get their heads around?
I think kind of one of the things you mentioned before, that, you know, it's not just street entrenched. There's drug use everywhere. There's lots of people dying. And I think people have recognized that. I mean, most people are like, yeah, I knew someone who died of, you know, or my friend whose daughter died. So it's become much more common. But I think it's still unrecognized as how pervasive it is in people's lives, whether that's methamphetamine, whatever, how common it is. And I think the second thing is to, I think the way to get sympathy for people is like to think that, you know, no one chose this. This wasn't really people's idea that they'd be in the streets and doing whatever, but there's circumstances that get people there. And that can be head injury, can be family life, all kinds of traumas that go on. And, you know, when I've talked to people who were at the Maverick, you know, we do an interview and they talk a bit about their history, and every time I'm just appalled to hear what these people have been through in their lives. And, you know, think to myself, how would I have managed under the same circumstances? Could I have done better? And obviously I have far more resources than many of those people, and I come from, you know, well-off families, so far easier for me. But you see people from well-off families slipping off all the time and having issues. So I think it can happen to anybody. It's much more common than you think it is. And nobody really chose that life for themselves. So that's kind of where the compassion comes in.
If we could change one thing that you think would make a huge difference, what would that be? You know, what should the public, you know, I often hear you want political will to change, you have to change public will. Public will drives political will. So if there's from that perspective, or from the perspective of just what people can do themselves, if there was one thing that people could focus on in moving in the right direction, what do you think it would be?
I think right now it's probably housing. You know, I wasn't as convinced before. You know, again, people have been overdosing for, you know, a big overdose crisis in the 90s. Housing was way cheaper then. It was still an issue. But that's driving so much of everything, is the economics of, that's just like the expense, the housing crisis driving people onto the streets, and then there's just easily available drugs. So I think that combination is so bad. So I think it's, you know, if you look for how to get people involved with drugs less, solving homelessness would be the big issue. But the second issue is safe supply. And we're never going to get away from all of this until we recognize that what people are getting on the streets is just poison. And you can say, oh, it's fine, give you poison, either take it or don't take it. And that's kind of the attitude in Alberta. So don't take it and then you'll be fine. Okay, well, that's okay, but, you know, we need to possibly have better alternatives, and alternatives that will keep people alive a little bit longer. So opiate substitution, great first step. Methadone, Suboxone. You know, never really, you know, meth is a huge problem. Mm-hmm. And what do we do about meth? And I've had this conversation with many people because, you know, we've tried substitution with Adderall, Vivance, all these other medications we give kids for hyperactivity, all that kind of things. They're amphetamines just like meth is. You can buy methamphetamine at a pharmacy. It's the same meth. It's just how you take it is the effect. But the problem is it's just not the same as injecting it. It's not the same as sniffing it. So how do we deal with that? And there's going to be some people that we're going to be able to say, hey, you know, here's some Adderall. And cool. that does the same thing for me, and I'm fine. But for a lot of people, the amounts we're giving them are successful. And so what do we do about meth? Either we substitute it. Fine. Maybe if you said, well, here's a set amount of methamphetamine every day, that's what we do for kids. We give them a set amount of methamphetamine every single day. We say, brush your teeth after you take it, and here's some good food. And those kids never have any problem. Once you go on the street...
We give meth to children?
Yeah. Methamphetamine.
For what purpose? Sorry.
ADHD.
Oh, okay.
All those drugs are amphetamines. And you can buy methamphetamine salts.
Okay.
Which is meth. So the kids get meth, same drug as what people take in the street. Why is it different? People in the street, they're taking it for a different reason. They're taking it to stay awake at night. They don't have anywhere to go. If you're a woman, I'm going to get raped, I'm going to get beaten up, whatever. They're taking methamphetamine, survival tactic, to stay awake during the night, to keep on going because they don't have to lie down. If I don't have any food, I take meth, I'm not hungry anymore. Maybe I'll drink a bunch of Mountain Dew. That's what my diet becomes, Mountain Dew and meth. What does that do to your teeth? Terrible teeth. But if you're a kid at home, you get the same dry mouth. But someone's there brushing your teeth, you got good hygiene, never going to have a problem. Keep taking meth, don't sleep, what happens? You get paranoid, get psychotic, start scratching, get all the ulcers, that kind of thing. Doesn't have the kids. They take a regulated set amount every day. The same drug. Exact same drug. Drug in the same class. Different effects just because of different circumstances.
When we spoke about methamphetamine in the past, you had talked about, treatment approaches for opioids versus treatment approach for methamphetamine. And at that time, there was no treatment approach for methamphetamine, really. Is that still the case?
Pretty much. So when I'd spoken to before, Australia had kind of gone, they'd have a terrible meth crisis. They have a lot of imported drugs, a lot of synthetic drugs. They don't tend to have as much opium type thing. And they tried the whole methamphetamine substitution, Adderall, whatever, and they just never got anywhere with it. And part of the issue is often you have to give people more, and they're also used to taking a different form. So if you give them something they can smoke, they'll probably be okay with that. Since the time we spoke, we've had COVID. And so during COVID, that was a common practice for people because, people use meth, they use a couple times a day. And you're trying to, stop COVID. This is in the early days. So, you're just going to stay in a hotel, and they were prescribing them Adderall or whatever. It was maybe did okay for some people. But like I said, most people want more, and they want it in a different form. So it's not always going to be successful, but they certainly did try that aspect of things. I haven't seen good results necessarily come out of that so far. I haven't seen anything published, particularly that supports a widespread use of that kind of tactic. So ultimately, for meth, we're kind of without any treatment plans. The thing that's tended to be most successful with methamphetamine is something called contingency management, which is even less popular than harm reduction. Because basically you say, well, look, if you don't take meth today, I'll give you $50. Your P-test comes clear, $50. Next day, $50. You don't show up, dirty Pete, no problem. And she'll pay you. But that was found to be much more successful than anything else. But it's pretty problematic from public perspective, right? You're just going to give people money to stop taking drugs. That doesn't go over well with the Paul Revere crowd.
So were they refraining from taking anything, or they were just refraining from taking methamphetamine?
Well, just for that purpose, it was just methamphetamine. So they just want to say, well, how many days of methamphetamine do you go without? And it could not necessarily be money. It might be housing, or it might be food, or whatever. And Carl Hart was a big proponent of this management. He's a neuropsychopharmacologist. He was one of the ones that did a lot of the research on meth, showing that whether you took a street meth or whatever meth, people couldn't tell the difference. If they took Adderall versus street meth, same thing. It's the same molecule. But he was also did an interesting study looking at motivation in meth users, because we have this idea in the public that you're helpless in the face of drug use, so you're just going to keep on shooting, that you have no agency, that you have no will to change. And he kind of was one of the first ones to do one of these studies where you give people money, like, oh, okay, well, yeah, I will take drugs today if you give me that money. And kind of said, well, and that kind of changed people's mind. Well, people can make decisions. They're not kind of slaves to the drug in that way. And it's not certainly perfect. People slip up, whatever. But so far, from research basis, that seems to be the most effective way of cutting down people's meth use.
How big of a problem is meth use in comparison to the other drugs that you deal, or the other drug-related problems that you deal with?
I think it's probably less from an emergency room perspective, because people will certainly get into that psychotic stage, and then often we have to deal with them, infections. But I think crack and cocaine are just much more common, popularly used than meth. And obviously the opiates and whatever else is in there is the thing that people end up in our place a lot with those. And of course the alcohol. The alcohol has become certainly far more worse after COVID.
So let's talk about that briefly. Because alcohol is not generally really thought of from a public perspective as, in the same vein.
Yeah.
What's your perspective on that? Like, you said alcohol has become an even bigger problem.
Yeah, certainly in COVID, people were drinking more. I've seen more of that carry on, and just kind of, I don't know, people are just home drinking, and that kind of, not even as much. I wouldn't say I've noticed it much more kind of in the street range population. It's more just within the people at home that people more still come in and like, oh, geez, your liver enzymes are way up, and I'll check their blood alcohol. It's like, well, you came in with a high blood level right now. Usually says something to people about the middle of the day coming in, that there's a problem. A lot of people in kind of smaller communities around the place, kind of, that seems to be kind of one of the routes they've taken.
Seems to go hand in glove with hopelessness.
Yeah, and I was thinking about that on the way here. Is there's this desperation, there's this hopelessness and desperation that is much more prevalent now, and I don't think that's just coming from the drugs. I think the drugs are a reflection of the overall situation of hopelessness and desperation that people are feeling now.
So we're probably going to be in this for much of the same for a long time to come?
I think so. I'm not sure how it's necessarily going to turn around. My kids are teenagers now, and I'm thinking, well, are they going to afford a house? Probably not. Most young people growing up today don't really have that in their vision, that they would be able to afford a house unless their parents buy them one.
Right.
So if you don't have a rich parent, you probably never own a house in your lifetime. What does that say from when we were growing up?
Mm-hmm.
Of course you get a house. Never. It wouldn't just be a duplex; it'd be a proper house, right? So there's, our whole outlook has changed from what it was before, from what success means.
Mm-hmm.
Because the things that were kind of going to be your success points for it, that's just out of reach now for people. So I think that's not going to go away for anytime soon.
Depressing.
Yeah. So, and I haven't seen any big kind of new things in drug management that they're going to kind of all of a sudden change everything. So, nor is there a big kind of, there's lots of motivation, pandering, but not really a lot of, on the ground practical research.
Mm. Speaking of research, you referred to earlier a couple of instances with how things are going in the UK, in Europe, and places like that. We had discussed in previous years, South America and places. Is there anything that other international communities are doing that is presenting new light, new hope on the horizon?
I think, some of the Nordic countries, they're very good at providing housing. And their drug problem is much smaller, I think, because of that. And they basically just provide housing. They say, here's a place to go, and it's much easier to get into that kind of system. So I think that is, that really cuts down their homelessness, obviously, and that's something that can be looked at. Portugal obviously decriminalized drugs, so they don't punish people, send them to jail, and I think that's been relatively successful. They have much better rates than the rest of Europe.
As I understand it, though, that they have a different judicial system there,
Yes.
with regards to the criminalization or decriminalization. That it's not just a decriminalization. There is, 1, 2, 3 strikes, you're out kind of situation with regards to rehabilitation or treatment programs.
I still think my understanding there is you still certainly there's treatment offered, but you don't necessarily have to take it.
Okay, I may be misinformed there, but
so I think that goes a fair ways to starting things out. Anywhere else in the world? The UK for a long time had prescription heroin, and that might come up again. They have decades and decades worth of work with that, and that may come up again now with what they're facing as far as the fentanyl goes. My kind of contribution or my thought now as far as a novel treatment would be the use of ketamine, which is another veterinary anesthetic most people know it by, but it's an anesthetic agent that I use pretty much every day in the emergency department. It kind of puts people to sleep and it dissociates them, so their mind just kind of goes somewhere else and has little dreams.
When I think of ketamine, I think of like psilocybin,
It does have some psychedelic qualities for sure, but it's not in the same family as psilocybin. It works on a totally different receptor system within the brain. Works on the NMDA receptors rather than the 5-HT receptors or serotonin receptors, which are what the psilocybin works on. And the interesting thing about this receptor system is it's also thought to be involved with something called hyperalgesia, which is when you experience pain is more intense. So we'll have people come to the emergency department, we put the blood pressure cuff, so painful. They've got hyperalgesia. They experience pain much more intensely. And that happens when you take opiates on a regular basis. Even after a week of taking opiates, your brain begins to sense pain more intensely. So that's kind of part of addiction in a way, or direct dependence, is if you have lots of pain all the time and it gets worse when you're on these opiates long term, then when you stop, you're going to have your withdrawal plus all this incredible pain sensation. So one of the kind of psychedelic drugs that's been used to treat opiate addiction in the past is a drug called Ibogaine. That's a shrub from Africa, and people eat that and have like a 9-hour hallucinogenic journey and vomit and all kinds of crazy things. But when they come out of it, they have zero withdrawal symptoms from opiates. Now, they can still go down and get some more and start up again, but the withdrawal's gone. And that drug acts on the NMDA receptors.
the same as ketamine.
Same as ketamine. So my thinking is a big part of the way that helps is by abolishing that hyperalgesia. That if you come out of that and you're all of a sudden not sensing pain terribly, then that's going to make it a lot easier to not want to take opiates again. So my feeling is that we should be, any kind of treatment program should be involving ketamine as one of your first medical treatments to reduce hyperalgesia, to increase your success rate for managing your opiate dependence going forward.
Now, from my understanding, correct me if I'm wrong, this is still at the clinical study stage, though.
Absolutely.
This is not something that you can go to your doctor and say, this is what I want to try.
There are ketamine clinics in in British Columbia, and you could go for them, but they're really at this point aimed at depression and PTSD. Chronic pain to some extent, because again, for people with chronic pain, take opiates, you can give them ketamine and kind of I don't need to take my opiates anymore, or I don't take them for 6 months.
Right.
So, but BCCSU is doing lots of studies on ketamine for substance use and PTSD and all these type of things. So we'll hopefully see some of that coming out. So yeah, it's absolutely theoretical kind of idea at this point, but with strong kind of bench research background.
So there's a lot of research out in the market that's been done, or in the community that's been done. Are you conducting a medical, study right now?
I'm just involved with the Maverick thing right at the moment.
So that's just
cannabis.
That's just
in
cannabis.
recovery. Yeah.
Okay.
As far as ketamine goes, I'm not involved with anything at the moment, but I'd be certainly interested in kind of starting up something once it gets approved, or if it becomes part of a program.
Right.
Crisis Storm will be right back after these messages.
Friends, we are ready for more steps forward in the inclusion of mentorship into our businesses, our boardrooms, local governments, and agencies. Our nonprofit AIMCanada Mentorship Society relies upon your donations and attendance at one of the awareness creating and fundraising events. Our annual donors either contribute smaller amounts monthly or do a one-time annual donation prior to year end. This is a request to donate now to support this docuseries and attend an awareness generating event, such as the upcoming Finding a Way Forward dinner with guest speaker Alfred Achoiba and Jeremy Neesaw as our musician. AIMCanada does community mentorship projects, such as the Crisis Storm podcast and the Finding a Way Forward documentary series. This is a 6-part docuseries for the city of Kamloops with a goal of filming all aspects of the social crisis we are immersed in. Aspects that include homelessness, mental health, addiction, overdose, increased crime, concern for business and community safety, and the communication breakdown. This communication breakdown keeps us stuck instead of traveling the path to find humane and results-orientated local community solutions. The Finding a Way Forward docuseries will be shared freely with the public, the business community, educational institutes, as well as local, provincial, and federal governments. Mastermind Studios, as producer, will be gathering and filming all voices affected by our community's social crisis. As part of the process, professionals will be interviewed, and leading-edge research and proven practices will be incorporated. Throughout the community engagement and interview process, we are modeling respectful and inclusive communication and interaction. With your help, we can achieve critical mass, find solutions, find community acceptance, and implement lasting change for the better. This process and docuseries will move our community forward and show all where we can play an important role in the solution. If you are part of the business community, please consider a corporate donation for the Finding a Way Forward docuseries or corporate advertiser of the Crisis Storm podcast. Perhaps become a corporate sponsor for one of our mentorship awareness events. You could also become part of our corporate mentorship registration program. Many companies and agencies already have a mentorship program. For organizations like these, registering in our national program can help them reach students, graduates, and communities throughout Canada, as well as become known as mentorship corporations. In closing, I'd like to say this Crisis Storm podcast series is our first action step towards providing documentary research and bridging into the Finding a Way Forward docuseries. If you are able, we ask you to support this valuable, timely, and critical work by becoming an impact donor, a major funder, or attending one of our mentorship awareness events with keynote speakers, or a corporate advertiser with the podcast series Crisis Storm. We need your financial support. Please act now.
With regards to the Maverick and and perhaps this is, maybe a question that should be asked of, Ask Wellness, but I had understood the Maverick being a transitional program back into community, back into the workforce, that type of thing. And so is there any concern with respect to the use of cannabis and then them entering back into the workforce and, not being able to pass a drug test, urine drug test or that type of thing?
I mean, that's always an issue for trades and mining and all that kind of thing. So, they'll eventually have to start going back to that job. But most of them are, taking their time before getting back to work. And, we've even had some success with working with WCB for different cases. So, on a case-by-case basis. But yeah, there's some jobs, okay, if you're going to go back to work as a pilot for Air Canada, well, it's just not going to work for you.
Yeah.
But if you're in that setting and you come out and maybe you don't go back to mining, but you go back to a different job, I think, that's still going to be a big success. And if it's going to be a matter of, well, if I take on the cannabis and my life is good and stable, well, maybe I won't go for a job that leads me to take a piss test.
Right.
And fewer jobs are doing that these days overall.
If you don't mind, I'd like to talk a little bit more about cannabis.
Sure.
Obviously, this is a topic that has been that most people avoid, but I think it's an important one to talk about. There's obviously we've had the decriminalization. We've had the government enter into the business of selling cannabis. You're an active physician and you've been an active physician in prescribing cannabis as a treatment for a long time. Maybe give us a quick 30,000 foot view of the efficacy of cannabis from a medical treatment perspective.
Yeah, I mean, things have certainly changed. So for my practice initially, there were a lot of 20 to 30-year-old guys, the back pain kind of thing. And now my practice overwhelmingly in those 60 years or older. And they are generally people who are interested in cannabis. They've heard about it from, other people in their social circle. They want to try it, but they just don't know anything about it. So they just need somebody to talk to and give them kind of an idea of where to start and really how not to have problems with it. Because right now it's very available. Like you said, you can go to all these stores, but those are recreational stores specifically. They're not allowed to give out medical information. So people really don't have anywhere to go. And I think that's one of the things that's been lacking in our kind of current setup is like, for the government to come out with 10 lessons for medical cannabis consumers. Like here's, some of the data and whatever, and here's how to use it. And I think that could have been done by anybody rather than leaving that to the private sector to take on. Companies like Shoppers Drug Mart have done some aspects of that type of thing. As far as efficacy goes, so certainly within my population, most people are looking at it for pain. They're in their 60s and they're, the golden life turns out to be a little tarnished with back pain and neck pain and chronic elbow pain or whatever it happens to be. They may have been on opiates, but the physicians have cracked down on opiates a lot over the last 10 years, so it's harder and harder. People don't have family doctors, so even if you were on opiates before and your doctor retired, you're not being on opiates anymore. So that's just become a lot more difficult to access. Plus, people just don't want to be on opiates overall if they can avoid it. The anti-inflammatories, super great, but by the time you get 60, a lot of people have stomach problems, kidney problems. They're not using any of those. They can't use either of those. So then they're left, well, Tylenol or what? So they're looking for alternatives, and that's where the cannabis has come in for people. And the biggest win for people is for those who have painful sleep. If I have somebody who's got tossing and turning from sleep all night, they say, oh, I got 3 hours sleep. I'm like, we got to talk, because that's something we can really have a big effect on. Because the cannabis oil, particularly at nighttime, you do a general imbalance of THC and CBD, and that really takes people from kind of 3 to 4 hours to 6-7 hours, and they can sleep and they go right to sleep, and if they go to pee and they go back to sleep and they're fine. So that's been a real rock star moment for so many people, because once they get to sleep better, the rest of their day gets better. Mm-hmm. Then they can start a little bit during the day. Sometimes we're just using CBD. We don't want to be intoxicating people a day, but even low doses sometimes can be beneficial for people as far as helping manage their symptoms.
You talked about oils for a second there.
Yeah.
So you're a pretty big proponent of using, sort of a sublingual or whatever.
Absolutely, yeah.
Application, not necessarily combusting something from a smoking perspective.
Yeah, I mean, ultimately, if that's something the patient says is the only thing that works, well, fine. I'm never going to say don't do something that makes you feel better. But even then, I'd say, well, how about a vaporizer? And a dry herb vaporizer heats up, doesn't combust, way better in your lungs, less coughing. Look into it, kind of thing. Get a good quality one, and you're set. But most people, really, when you're talking about smoking, most people are doing that recreationally. You want that high blood level to come up. With pain management, we're looking for a long, steady blood level. Totally different idea. So you're looking for an oral product that's just going to last that much longer. But I have some people with anxiety issues that find the CBD vaporizing pen is very helpful for them during the day. We have creams and rubs that people put on their joints and hands, and we got almost no research on that. But I got people who are like, this is amazing, it helps me so much. There is some research on using cannabis oil for wound healing. And so again, not much, but again, I got people who use that for the psoriasis type thing that report good outcomes. PTSD, again, comes in the nighttime. A lot of people are affected by nightmares, and the cannabis can really cut that down, really decreases nightmares at nighttime. And then I have a few either autistic kids or kind of behaviorally challenged adults in institutions who may use some CBD during the day, some THC at night, or for sedation and sleep, just for behavioral management, just to help out with in their care, so they're not having emotional outbursts, or just more easy to kind of get along with during the day.
So how did we get to it sounds like there's a lot of efficacy with regards to cannabis. How did we get to the point of North America especially in just shutting down cannabis use altogether for decades and decades and decades, if it's such a wonder drug?
Well, I mean, it was a medical drug for a long time. Queen Victoria's physician gave it people. Who's that guy here? The physicians in Canada would carry it around in their bags. So there were two issues that came up. One was cannabis is fat soluble. It's messy. It's difficult to deal with. Morphine, all these other things, water soluble. You can inject them. Way easier to manage. So that was one thing. Second thing was racism. Mexicans. So in the South, you have tension with immigration, as we still do today. Mm-hmm. And the marijuana that people got from the pharmacy was an oil kind of thing. They weren't smoking. All of a sudden, you had all these Mexican immigrants, and they were smoking this marijuana. And there was crime inevitably, or crimes blamed on cannabis. So it became illegal based on fears about Mexicans coming in and taking jobs.
Into the States.
We had the same thing in Vancouver with opium. So you could buy opium from your pharmacy because that was produced by Britain, which was the largest drug dealer in the world at that time, pushing opium all over the world, pushing it to China. So you could go to the drugstore in Vancouver and get your opium tincture, but you weren't allowed to smoke opium. That was illegal. That was only done by Chinese people and by white women who were being corrupted by Chinese people. So that was a whole big scandal. And there was this massive riot in Vancouver. And from that point on, opium was basically out. Couldn't get opium anymore for the general public. And the big problem is that they were trying to bring Chinese opium in. And that would compete with British opium. So that can't happen. So that was all economic and racism. Cocaine mostly became legal in southern U.S. White people could take it no problem, and you could actually get it in Coca-Cola at the time, right? In a soda fountain. So you have to go in the soda fountain and get your cocaine, go into building it cocaine. Then they started bottling Coca-Cola, and anybody could get it, even black people. And there became these stories of black people becoming enraged, out of control, attacking white women, insane on cocaine. Sheriffs were buying bigger guns to stop the crazed black cocaine users. So cocaine scare because of black people using it. White people using it was okay, but now black people were using it. Cocaine went away. So opium, marijuana, cocaine, all legal in North America due to racism or with a racist tie-in. And so, for example, it was really referred to as marijuana because nobody knew what that was. That was a Mexican word, Spanish word. Nobody knew what cannabis was. That's what you got at the store. But they didn't really connect the two. There's big steps made to not connect the two, that marijuana was the bad thing and that needed to be outlawed.
And then the big, the big things
drug war
with the Reagans and
Nixons, and Nixon, they were on record as going, we can't really criminalize black people and hippies, but if we criminalize the drugs more, then we can get them through that.
Right.
So, then you get the crack cocaine disparity where, if you get caught with 5 grams of crack, you get the same sentence as someone who has like 100 grams of cocaine. Because white people use cocaine, black people use crack. So there's this massive sentence disparity. That's all the black people go to jail then.
So do you feel that we're moving to a more open, more accepting society, and that is part of the answer? Or do you find that we're still very polarized?
No, I think it's very polarized. And I think still we see, if you look at Downton East Side, you'll see massive Indigenous representation, far more than so why is that? It's not like they necessarily use drugs more than we do, but their circumstances are certainly different. And, all the residential school history is up. Well, sure, not a big surprise that when we're ending up. But I think there's still that impression that you had that, drugs aren't used by good people. They're used by those others. And that's always been a big struggle with stigma and drug users is they are the other. And once you put them in that other category, then you can jail them. You can just let them die. You can not worry about them because they're the other.
Well, you've definitely given us a bit of an education and opened our minds to some other possibilities.
Well,
do you have any sort of closing thoughts, things that you think maybe the people, in our community especially, should think about?
I think, we all want to make this our home. This is a beautiful place that we're all fortunate enough to live in. There are some real problems that we face, but harshness and cruelty are never going to be the answer. It's never going to fix things to the way that we want them to be.
Thank you, Ann. You've been watching The Crisis Storm from Mastermind Studios and AIMCanada Foundation. Thank you for watching.